Hopefully that's working okay, and then I'll make a start. So thank you for the invitation to share the findings and the outcome of our seed corn project, which was funded from Better Health and Care work. My name's Matthew. I'm a physiotherapist and a Professor of Health Services Research and Rehabilitation. There's a larger team doing this work, of course, but I'd like to acknowledge two people in particular. Firstly, Dr. Joe Bailey, who's a physiotherapist and postdoctoral fellow working in a lot of from Joe's and clinical experience. And then also Dr. Natalie Sinclair Sullivan, who was recently a PhD student, and she's recently gained her PhD. The topic of this work is really relevant, and Natalie helped us in a fantastic way. And assistive devices or assistive tech. And this is really like the things that people use in this case to help them move around, both in and around the home. And we're particularly thinking about mobility devices, so walking sticks and canes, and you can see from the slightly old picture of my children, what we would call a relator, a frame that's got some wheels and handles and would help people typically move around outside. And these look quite clunky and they look quite medical and I say boring, but they're very standard and they're not attractive to many people. And this forms part of the problem we're trying to address. So we're all aware of a very kind of ailing population, and many people are living with multiple conditions, and as they accumulate different illnesses and live with the symptoms of those illnesses in their treatment, falls can be a big problem. People fear falling, and they often reduce the amount of mobility that they're doing in everyday life. Lots of just world, which is really the result of their symptoms, perhaps breathlessness or pain or fatigue, and also the changes which happen with a lot of illness, making their world that much smaller. So they would find it more difficult, or would struggle, or would less frequently get out and do kind of important social activities and meet other people. And despite the kind of importance in the growing problem, that's not really being met by engineering and mobility devices. Don't really moved on in the decades. The time that people have worked in clinical services, they can still remember work of and working around the products which we see, which look, around the hospital grounds. And this is what people are given if they have the chance to discuss their mobility. And the companies really are investing very much in like high-end, fancy technology. The kind of chief exec of an engineering company, then I would be investing my money in the latest kind of innovative product with lots of sensors and lots of accelerometers, and as a result of that, a really high price tag, which is kind of unaffordable and not really aligned to the frugal solution which is really required. People just want these things to be a little bit more functional. Of our project was to improve aspects around the quality and the acceptability and then the uptake of assistive devices. And we had this particular focus on indoor and outdoor mobility, many devices which support other aspects of functioning. And thinking about these kind of concepts, we were interested in the quality and the acceptability of products, and that can be a number of things. It might be product may initially look to the potential user. It may be the way it's talked about or introduced in a kind of sensitive or non-sensitive way in a healthcare service. With the potential users of these in healthcare engineering, then that might help us kind of edge this work forward. And in real life, that means making products from there the patient will want to take. So we did different things in this study over about an 18-month period. And as I say, it was a seed corn project from the hub. The first thing we did was a scoping review of the literature. So with support from the colleagues, we looked at the literature for any use of assistive technologies, that's devices which help people function, or products which help people function in the context of advanced disease and in palliative care. And we did that work and published in this journal, Disability and Rehab Assistive Technologies. It wasn't quite designed for our work, but you can appreciate it's a really, really perfect fit for this kind of systematic review. We found a very limited evidence base. I think there was kind of a dozen or so empirical studies of all assistive technologies in this setting overall. There's a kind of neglect of this kind of field in the scientific literature. And where there is research, it tends to be focused on people with progressive neurological conditions, particularly motor neuron disease. And it tends to be, again, those quite high-end devices and lots around communication, devices which will help recognize intention to speak and would help people communicate with others for kind of social engagement. We found some gaps around the product design strategies and the ways in which people had undertaken research to help people find products which are most accessible and help people uptake the device. Product are manufactured and are integrated into service delivery. So there's a real important space, but really ripe for limited field. And then although there's very few kind of controlled studies and there's a lot more kind of evaluation reports than clinical trials, there were lots of aspects around the ways in which this kind of technology might help people become more independent, help their autonomy in everyday life, and importantly to maintain their kind of social connections as an aspect of quality of life. And with people living with advanced disease, and as people progress and their kind of body declines, then the fit between that person and their environment becomes all the more critical. And with simple interventions with this kind of device, we can really change people's level of functional ability and help change what they can do and their experiences of everyday activities. The second piece of work was around some interviews, and I think this was our side of the when interested engineering colleagues. We've got lots of strong links with our clinical colleagues and clinical services, and in this work we were able to work with St Christopher's Hospice and some of the palliative care services to undertake an interview study of people who are living with and experiencing advanced illness and are living with the kind of symptoms and concerns and outlook or life perspective that we really need to get to if we're trying to understand kind of end users and preferences and requirements for this kind of device. So we did several interview studies which were specific to this study. Some analysis of assesstive so video in PhD advanced cancer, and he'd undertaken some longitudinal interviews and within those about people's perspectives and experiences of mobility devices. So this kind of insight is only possible when we've got strong working relations with clinical teams and a kind of to undertake quite sensitive and quite meaningful interviews around loss ultimately condition. But just read the kind of on the left side of the user requirements, what people told us was important when they were thinking about or deciding translates not quite kind of in a paired way, but across from left to right into the technical requirements for these devices and how we might improve the design of mobility devices to make them better quality and more acceptable, and therefore to increase the uptake and use of them. So you can see people talked around the ease of use and the comfort and the safety of these devices. And for people who'd had a try or were using these devices, there was lots around very straightforward things around the comfort and the safety of devices. They wanted this kind of ideal balance of a device which was light enough to be maneuverable and kind of navigate spaces, but solid enough that it doesn't become a kind of fragile device and something which people didn't feel this feeling of safety within. And is also portable in that people can move it in to outside their home. People can transport it without someone else needing to be there. And they also talked about lots of practical aspects. Many of the kind of standard devices won't get through a door frame. For anyone who's pushed a buggy around a shopping centre, it's the same problem that people are encountering. It kind of restricts what you can do, where you can go, and the pace in which you can undertake activities. And people also talked about the kind of emotional and lifestyle needs and how these things were viewed outwardly. And so the designs, people told us they feel a little bit old and standard and clunky, and that kind of exaggerates this feeling of dependency. And there's limited aspects. So there are lots of ways in which, as a designer, again, put your mind in the kind of manufacturing and engineering headspace, you could make these things more comfortable to use, more portable, and at the same time maintain that sense of durability and safety with lots of different kind of features which may be possible to do, and lots of customization and accessories. I think a really kind of interesting and new part of this work was also a collaboration directly with colleagues in the engineering faculty. And we worked with the Institute for Healthcare Engineering, Professor Maddocks, who's in the middle with the red t-shirt, and many of his postgraduate students who are taking engineering courses and qualifications, and used this project as a means to undertake their and we had lots of interaction across email and helped each other with our thinking and shared our thoughts and understanding about the user requirements. Gail in the striped t-shirt is one of the physios who work with Vincent Christophers. And then their development and their thinking as they focus on aspects of mobility device design, which they as part of their group, they focused on STEM and how brakes could get this painful and will become some exhibitions which we wouldn't usually go to. Often these are kind of occupational therapy or but that's called NADEX, which is kind of Europe's widest and largest innovation display. And again, they reiterated and found these feelings that lots of the investment, lots of the passion is on very fancy chairs, which might cost thousands of pounds and would move people around in a very fluid way. And the companies tend to have a standard offer of this kind of simple mobility frame, a relator or a walking frame, but it's not really where their efforts are spent in terms of design improvement. And there's this gap or relative neglect of this kind of frugal and low-tech solutions at the expense of more fancy and more expensive products. So through the work, we've also made opportunities to work with some policy centres, including the Europe office of the WHO and an organisation called AT Scale. This is an organisation which is hosted by the UN and is really interested in improving global access to assistive technology. And they do that through almost any way apart from manufacturing and selling devices. So they help governments understand the potential of assistive technology. They help people with pricing structures and localize manufacturing, so there's less steps to the end user. And they help services and health systems appreciate where assistive technology may fit within their work. And we can't share the details, but we've got going through the kind of final approval, a policy brief from the World Health Organization on assistive in palliative care, and then a brief from the AT Scale organization called Why AT Matters in Palliative Care. And these are great kind of complementary offers to use of requirements, long-term use of devices. And in both of those outputs, we've summarized these kind of key considerations, which we think are particularly specific to palliative care. And they're kind of a blend between the acute use of this sort of equipment in an orthopedic setting when someone might be recovering from let's say, a hip replacement, and then the long-term nature of device use in an aging population without rapidly progressing function. There's very short-term and changing needs of our populations, and people have glitches in the design, which will be felt in relative terms in a better way. Empower their agency and autonomy rather than kind of restricting and disabling use. And we need to integrate these sorts of devices and connect communities across palliative care and rehabilitation. And we've understood through this work, I think, that it happens both ways. Our rehabilitation colleagues and communities must appreciate the role of technology in palliative care and towards the end of life. And conversely, the people who are very primarily palliative care focused must appreciate the role of function and the relevance of rehabilitation in their provision. So it's part in terms of the devices being attractive to different people and giving a sense of kind of personality. And then to finish, and what next? Well, we're working with our colleagues in the university from this development work, really with the leading manufacturers of these sorts of devices. So we're going to try and start a company and design and manufacture our own product, but we really hope that user understanding and some of this design thinking can be used to those companies already manufacturing these things. And care services and the ways in which this kind of equipment is produced and delivered in practice. There are a lot of sensitivities and a lot of communication skills, as well as the kind of the ways in which equipment can be timely matter and place those people's go ahead. And then I'll leave this here, but while I kind of people on for this, it is show how this work is very close to fit with the values of Better Health and Care Hub. We're very interdisciplinary in our outlook. There's lots of co-design and understanding the user requirements, and there's lots of use of evidence in this work and as we go forward. So I'm about over time, but thank you for your attention and look forward to questions in due course. Thank you.
Thanks, Matt. You're too self-critical. You're perfect on timing. Absolutely perfect. Thank you very much. We're going to go straight into the second presentation, and then, as Matt said, we'll take questions on both presentations. I'll get up talking.
I'll just crack on. So yes, I'm Dr. Liam Gabb. I'm a palliative care doctor by background and currently an NHR fellow doing my PhD looking at meaningful dying in dementia with Professor Catherine Sleeman, Professor Catherine Evans, Professor Gareth Owen at CSI and OPPN at King's. Just a little disclaimer before I start. Whilst this research is funded by the NIHR, as always, all views expressed are my own and don't necessarily represent the views of those of the NIHR, NHS or Department of Health. So yes, I want to talk to you about making sense of dying with dementia, finding meaning when living with dementia as a life-limiting illness. Just before we begin, a bit of context about this that I'm sure might be familiar to many of you. We know the number of people affected by dementia is rapidly increasing, and it's already the leading cause of death in the UK and 7th globally. Worryingly, we can see that dementia is the fastest increasing cause of serious health-related suffering globally and predicted to worsen over the next 40 years. Despite these needs, current services are not tailored to meet the needs of people dying with dementia. And when speaking to people with dementia to develop this project, models of how to care with people with terminal illness, such as the good death, that design people with cancer in mind, really don't speak to the experience of people with dementia. Wider work on living well with dementia has looked at respecting a person's values and preferences as essential components of person-centered care. And so we posited that perhaps exploring what can make the process of approaching the end of life more meaningful might provide a lens to find a more nuanced understanding of the end experience of people with dementia. It's a 3-year project, and it's quite a busy slide, but just give a bit of an overview of how it all fits. In the blue on the left there, we have and taken that to do some qualitative work and interviews with people with dementia, explore their rich both so you can see on the right, which is a discrete choice experiment. Differences are relatively valued and trade off against each other. We can't have everything. Along the bottom here in pink, you can see we've related all of this back to wider literature. So that's philosophy, psychology, sociology, religious studies, and more, alongside healthcare literature, and alongside multiple discussions with people living with dementia and other stakeholders to sort of iteratively develop an empirically informed theory of meaningful dying in dementia. I want to begin by talking about the results of the literature review. This was a Assistive review, included 60 studies, both qualitative and mixed methods, worldwide. About 16 different countries were included, looking at the views of people with dementia, carers, and health and social care professionals on what provides quality towards the end of life. That's what's important, what matters at the end of life for people with dementia. And then analysing that to a sort of framework of meaningfulness. And what we found is that the person with dementia really has to sit at the core of everything we're doing, but that their identity and who they are is shifting and changing. Whilst it's really important to recognise the person they've always been, to cite back to what has always mattered to them and keep that in the forefront of our minds, actually with incumbent changes on their cognition, people may change, their personality may change, their preferences day-to-day may shift, and that might be in conflict with who they were in the past. And we need to be able to adapt what we're doing to meet them where they are in each day. At the same time, the future that they're facing may shift. So people with dementia in these studies often spoke of losing their future, not being able to project forward, it being impossible to imagine a time when they're no longer themselves because of the cognitive changes, or just fearing what their future may look like as something terrible. Whereas carers and healthcare professionals in these studies tend to look more about how could we plan and prepare for the future to try and avoid crises and things going wrong. But interestingly, there was a real tension between these 3 different aspects of a person's identity, and that they shifted and changed over different times, even over a day, but certainly at different stages along a person's journey with dementia. So there's real temporal change and shift for the person. Around this person were 4 core themes. The first of these, bodily comfort, recognise the importance of the physical integrity of the body of the person with dementia. That's say for a lot of people, they were really worried about being in pain, or of having the right amount of nutrition that was appropriate to their needs, or being well cared for and well presented. And the physical body was really important to look after, as it sort of integrated how they related to the world. alongside this was supporting the connection and relationships of the person. So recognizing family relationships of the person with dementia and how important and valuable they were as two-way reciprocal interactions. And interestingly, for some of these important relationships were taken on by care staff at nursing home, and these became trusted, almost familial relationships that fostered and facilitated a trusted and meaningful environment. The next was contribution and legacy. One of the big themes that came through all of these studies was the high levels of existential distress that people could feel, with dementia may feel, when faced with the changes of dementia. No longer did they have the same role in the family that they once had, or their same role in their work. They were left feeling purposeless, or like they were merely a burden on those around them and society. So it's really important for their sense of meaning to try and find ways to make them feel like they're meaningfully contributing on a day-to-day basis. And particularly when thinking about living with dementia as a life, and what behind that might be the people they touched and the memories and the story that they left behind, and how important telling those stories and reminding those things are. Fourth core component was recognition of the spiritual self. Now, for many people, this was their faith and might be small, everyday acts of personal faith, such as prayers or hymns. It wasn't big acts of large sort of spectacle or ritual, but these smaller acts that were important. And sometimes it was merely being around other people who held the same faith or the same sort of religious people being around to provide that sense of familiarity and support, and that in itself alleviated some of that existential distress. Underpinning all of these was an approach that respected the person within the illness and ensured we maintained their dignity at all times. So recognizing who they are, treating them with kindness, with compassion, respecting their choices and their ability to make those choices where possible. And as you can imagine, all of these different things are complicated in dementia and may interact or conflict. And it's often that it's not possible to maximize all of them. And so it was necessary for many people in these studies to be able to take a step back and look at what was happening overall, relate it to the personal story of the life this person had lived, what had happened up to this point, and what was happening now, and try to make sense of it and find a way of making it coherent and one whole story. Now, this might, earlier in the journey, be part of what the person with dementia could engage in, but later on was taken on by those around them and was undertaken by sort of having an environment around the person that enabled that and fostered that meaningfulness and sense-making. But of course, that wasn't the whole story. It's a mixture. Experience, particularly thinking about what provided meaning in their lives. And so we went and did a further study working with people with dementia, and we had 10 participants because we spent time doing something called photo elicitation. So we gave them a camera, we asked them to go away over the next weeks and take photographs of things in their life that provide meaning to them, and in particular provide meaning when thinking about facing the end of their life and coming to the end of their life. And then at the end, I collected their photographs and went back and had interviews where we just talked about those photos that the person had taken, so their own photographs. I didn't go with a topic guide, it was really led by what their photos brought up, not trying to remember what they'd done before. We found sort of 5 main themes coming through of these sort of lived experience of these people with dementia. The first was a familiar and lived space. So being something potentially in their own home is well known, or at least by objects that story up to that point. So for one, and this was a series of stuffed toys that had been with them from various places they lived throughout the world that represent the story, and even when they couldn't remember their own autobiography to hold their sense of self up, these objects could still do so for them. Sorry, Abby, I can see your hands up.
Sorry, that was accidental. Sorry.
Oh, that's okay. So these objects sort of upheld the selfhood of this person, and they were able to say, even when they couldn't remember why they were important, they knew they were important because they were there and they placed them intentionally. And so having these meaningful objects to create a meaningful environment facilitated their selfhood. The next was their relationships and the sense of belonging that was achieved through those. But these were wider than just familial relationships. They extended to friends, trusted care staff, but also non-human relationships. People talk about the companionship they got from pets and being around other living things, and a sense how they physically that allow them to live in ways that are meaningful to them. There's also this sense of lived connection to something greater that came through, which for some was their faith, but for others was things like connection to nature or music. There's a quote on the right here of a woman with dementia said in the study, "The trees just give me a feeling of peace, real nature, oak trees, and just gives you peace, and yes, a feeling of joy even." And that was one of the things that framing this discussion around meaning, we found that, as this sort of quote indicates, it wasn't just about the needs or losses that are being faced with dementia, but instead, how can we provide a more optimistic or hopeful or joyful experience through finding that meaning? Finally, the fifth theme was of telling the story to make sense of lived time. Similar to as we saw in the conceptual framework of the review, people with dementia had this complex relationship with time of struggling to remember or this good future. And by telling the story of who they were, almost all of my participants began by talking about their family history or why certain things were important because of how it had fed through things in their past. And by telling those stories, they were able to find meaning in the place they were now. But one of the difficulties we have is that we can't have everything. We found all these preferences and things that are important, but we know we are working within systems of finite resource, and that many of these preferences might come into conflict where we can't have two things because one is very difficult in a certain setting, for example, staying at home and meeting certain care needs. And so we wanted to then look at, well, how much are each of these things valued? And how do we start to trade them off and weigh them up against each other when we have to pragmatically choose? And to do this, we've undertaken the third work stream, which is running at the moment, discrete choice experiment. Here on the left, you can see an example of one of the choice tasks that we gave carers. So this had two arms, one for people with dementia and another for current or bereaved carers, with the current or bereaved carers receiving slightly more complex choice tasks. But basically, we give people a series of hypothetical scenarios, like the one you see here, that have a number of attributes. So whether the person is known by those caring for them or their family can be with them, being one, whether how comfortable they are, so they're severely uncomfortable, moderately, or very comfortable, where they are in place, so whether they're at home, hospital, or a nursing home either feels familiar and safe or familiar, whether or not they can get outside into a garden or have no access to nature, and whether or not their care is a burden on those close to them or not. And then finally, we also included a cost attribute, thinking about the out-of-pocket cost that this may involve for them. It's around the sort of estimated nursing home, £1,400 a week, which would be the cost of a private care home, and varied up to that from about £100. People with dementia had almost the same attributes, but just without the garden and burden, in order to limit the amount of, sort of cognitive processing that was needed to complete the tasks. And so I've got some interesting results. It's still undergoing, so I want to just interpret a little portion. We have our first 50 carers back. And as you can see on the graph on the right here, we're all some really strong patterns there. So this shows a willingness to pay us on the x-axis. We have versus known or not, as to not being known. We've referenced that around that cost attribute to work out, based on their choices in these tasks, what would they have that thing compared to alternative. And the thing that's was that the person's comfortable. We think that the magic that is something people were actually willing to pay to ensure that person was uncomfortable. £3,000 a week compared to being uncomfortable. So really valued to look at place to the right of where the high familiar hospital. And what we can see is an nursing home here seems to make that's in hospital for carers. Were both significantly more valued than being in hospital or an unfamiliar nursing home. But there wasn't really much difference we could see between more numbers go about 70% of our carers here were bereaved, and a significant portion just of the person had been with dementia in care. So maybe that's already know about this advanced needs that they have to be, and sort of budget their choices based around that. The other thing that comes through here is that being known is really important. And actually, for our carers here, it was less important whether family were there or not, but just that the person around the person with dementia, that those people were known to them, and that the person of them. Also, getting out in the garden or having access to nature was really valued, as was not being a burden on care. So even those lower ones were still around the family. And all of these numbers of the cost of £1,000 a week, etc., are quite large. And it's not yet clear. We'll be able to try and tease it out with further analysis, whether this is because people doing hypothetical choices just ignore costs and think, I'll pay whatever to give them what I want, or whether it's to do with our sample. A significant number of our carers, most of them were homeowners or had a significant amount of savings. So I think about half had over £35,000 in savings, which might mean they felt more able to pay for these higher things. But some interesting themes already coming through these small numbers. The theory of meaningful dying exists overall, and we're really looking at emphasising making sense of the dying experience as a whole, but that not all preferences within that are equal. And indeed, comfort may be important, more important for some than preferred place of death was achieved for whether we achieve good care for someone with dementia. I'd just like to emphasise that people involved with the PPO project from its design all the way through to its analysis that goes. I'm hugely grateful for their input. And so I'd like to open up for discussion. I know we're going to have many questions, but some of the thoughts I'm having with this work now is about how we begin to take this into practice, to reach impact, to broaden definitions of quality. Means sessions and Rehabilitation. Thank you.
Application, Matt Apple. Okay, we'll open up the questions now. So any questions or comments either raise your hand or you can pop them in the chat.
Hi, thank you. I won't ask Liam a question because that would be, but well done, Liam. And well, I'll make one comment on Liam's talk, which is that he kept on saying we've done this, and it's all clear. Very much your work, Liam. A question for Matt. I was really interested, well, particularly because Matt through this parents in the sense that their house is way more full of these types of bits of equipment today than it was a month ago. About the sort of those listed them. I wondered if some are clearly more important than others. You emphasised the kind of lifestyle and personalisation and design type side. I think my parents couldn't care less what something looks like as long as it's safe and effective. So I was just wondering about that.
Yeah, thank you. Yeah, I mean, the people that we interviewed, and so the people where those findings came from, were in a relative to that more stable condition. They're probably in their last years of life, but they were experiencing, decline over a series of months, and so they were probably making and struggling with some of the choice of taking up these devices for outdoor mobility. And it's just a very different situation to people who are receiving a device after they've had some surgery. and there's a lot of meaning attached to that. People, it's a very outward and obvious sign of decline, and they see that something which is always going to be there, and they don't see the use of this kind of equipment as we would professionally, as a kind of enabling and supporting equipment. But I think it's probably very different in the more acute, day to day and maybe week to week time frames. And I think there, really, what we've learned is how important it is to have services which are responsive to those rapidly changing conditions, and they're not guaranteed, and there's a sort of very haphazard provision of this kind of equipment. There's a by anyone, and it spans health and social care, and it spans different teams. And I think in our health system, there's also lots about accountability and maintenance of any equipment. So there can be all sorts of delays and pauses to get the person or the service into the house and providing appropriate equipment. And then once that happens, the next difficult step is there's an accumulation of equipment, because it tends to get added to rather than replaced. Now, there are some examples. There's one that we're aware of in Canada, in one of the provinces, where there's a very separate system for this kind of context, and for people who are receiving any palliative care involvement, they get more rapid access to assessment and provision and replacement of equipment. Definitely can be. It's the orthopedic type models very quickly. It's not the usual business of community rehab provision, which is a little bit long and a little bit slower. Those personalization bits are the aesthetics of frames, but there's also some they can and to feel comfortable and confident using the equipment as well. So there's definitely a lot of service and sort of systems questions which have come up.
Thanks, Matt.
Okay, thanks, Matt. Thanks, Catherine. So there's a question for Liam in the chat from India. Did you plan to recruit people with dementia to your DCE study? If so, have you been successful?
Thanks, India. Yes, we have a separate arm of people with dementia. So we've been only open for a couple of weeks now for the full recruitment, and we've got 2 completed with dementia and another 11 or 12 booked in to complete their survey in the next week or so. So we are getting some numbers, but it's slower than the carers who are able to self-complete. In order to help the people with dementia complete the survey, I'm delivering it face-to-face, either online or through visiting. So it is a bit more work, and we're expecting to probably have a slightly smaller person with dementia sample compared to the carers. But yeah, it is working, and they seem to be able to do it. And nicely, they'll actually be able to do complete the task in the pilot that we did. They showed they were able to complete the tasks. But they are milder, understand the projects and engage, rather people with advanced dementia, advanced cognitive impairment.
Okay, thanks, Liam. And another question for you in the chat, and then I'll come to Fazia, from Sandra, whose connection is poor. Well, firstly, really interesting presentation, amazing work. But Sandra's question is around thinking about people living in higher socio-economic deprivation. Concepts of paying thousands to ensure good outcomes for their loved ones may not be comprehensible or possible. How can your findings be translated to economically deprived populations?
Yeah, thank you, Sandra. Really important question. As part of the wider survey, we have the choice tasks, but we also have a series of other questions that include some graphics and testing question they would use for assessing contributions to care in real practice. Around the island, or Northern Ireland or Wales or Scotland. Hopefully, if we have the numbers, be able to tease out whether how much things are valued and how much people are willing to pay for them is different, and there's a different sensitivity or different based on where someone sits socioeconomically, so that this isn't just sort of population overall or thing. But as I said, so far the population has generally been more affluent, and we're still still working on numbers, but we'll be able to do a bit more analysis and hopefully tease out further to try and understand if these are differently valued for people.
Really important subjects, and of your items being personalised. I just wanted to ask whether you've thought about the sort of life cycle of the devices in terms of, sort of reuse and recycling as well.
Yeah, we did, and Jo Bailey's on the call, and she's very interested in the kind of sustainability and green aspects of these. There are even some systems in the UK where the charities and banks, where the equipment gets cleaned and sanitized and spruced up again for the next user. And if you look in the windows of the charity shops, you will see good equipment that's found its way into there. It's just become a bit of a kind of system responsibility. And actually, the students who joined the collaboration, they're undergraduate students, and for their project, they focused on the handle design, and they made a kind of handle that fitted people's grip and was comfortable but stable. But they also put their heads together, and they've developed this kind of company that does wraps for walking sticks. And I think they're either registering, or they've probably even got further through the system, and they're able to sell the kind of low cost but important personalization aspects to these things. So I think it's the sustainability aspect and the kind of systems which can work efficiently and work well for the users. It's a great opportunity, I think, for many people. Thank you.
Great. Thanks, Matt. Thanks, Fauzi. Any other questions or comments for Liam or Matt? If not, I'm going to take chair's privilege and ask Liam a question. No, okay. Liam, I wanted to ask about, I'm really interested in the photo elicitation study. I've used a similar method in a different context around head and neck cancer patients. And you get such a range of photos back, and the participants take such a different approach to what they decide to photograph. And if I understood your study correctly, the attributes that you used in the discrete choice experiment were informed by the themes that you identified from the photo elicitation, I think. I just wanted, it's a bit of a nerdy methodological question, but how did you get from all of those photos to the wording and phrasing of those 5 themes, which then underpinned your discrete choice experiment, I guess?
Yeah, thanks, Glenn. A lot of work. So we did a couple of things. So we used the review as well as the interviews, and rather than using those themes directly of sort of we used a form of hermeneutic phenomenology to analyze the interview data, which obviously gave these really rich themes, but we just did some more sort of descriptive level. What was the content of what were they saying was important, and then presented a mixture of sort of generated a big long list of the types of things that were coming from the review and from that, and then presented those to PPI and did a bit of a ranking exercise with those. Looked at the top, I think we had 5 or 6, maybe even 10 that they'd ranked, and worked out which were actually tradable within a discrete choice as well. And so then took those out for which of the attributes to include, and then have done some more PPI work about the wording used, and then did a pilot of the DCE to make sure the language worked in the study, where I did sort of think aloud interviewing, collected all the data and feedback, and then redesigned it and did it for the full version. So it sort of was several steps with lots of little bits of study to get that design, to get what those attributes actually looked like.
Great. Okay. Thank you. Thanks for clarifying that. Questions or comments for Matt or Liam? stored one up from Matt as well. So Matt, you've done all this excellent user-centered work. You've developed these design briefs. You're now going to work or hand these over to companies who are going to perhaps prototype some of these frugal innovations. But you mentioned on the first, I think it was your first or second slide, about procurement processes. So in terms of impact of this work and getting these new devices to the patients who need them, the procurement processes are obviously fundamental. Has anything come out of your research to date, or are you going to be doing any work in the future thinking about how do you get these devices actually procured?
Yeah, I mean, it's quite new to me, and I find that an interesting part of this 80 scale organization, because they for example did some recent work about reducing the number of steps and people and organizations involved, from the manufacturing to the patient. So and if you can have a smaller number, there's less need to generate funds to support each organization and therefore get the cost down. And even in in palliative care, they've got a I was going to call it a shopping list, a central list of medicines and equipment. And they made the comment there that the current wheelchairs are just too expensive to get on that list, but they're such an important provision that should be available worldwide. So I kind of personally very interested in that, and but when we were taking advice from the enterprise team, they were just encouraging us to kind of support the existing leading manufacturers. I think some really helpful advice was that if there's a product which looks something like what you envisage, then just work and reach out to that manufacturer and that company. Don't try and compete in that way. So we'll try and do that in a kind of sensitive and interested in helping and working with you way, and of course guided by the kind of expertise from that team. But I think that's how we would like the product to get slightly better and then be able to get they're not hugely expensive. For many people, the ones in the photographs are kind of, I don't know, less than £100. And a very fancy walking aid is less than £200. So considering the amount of change that they can make, they're kind of potentially the sort of technology and product that people would be able to and would want to invest in. Whereas I think in other countries, I think in India, for example, we had a meeting to their National Cancer Hospital, and they have to do it under $10. That's the kind of price point for the piece of equipment. So, but they are low cost and frugal. They're not high end. Let's build in all the technology to increase the price point.
Okay, great, thanks. And we have just time for one more comment from Ivy. This is for Liam. Just wondering if caregivers shared more about what sort of comfort were they looking for, such as comfort measured by facilities or by the people with dementia's feedback.
Thank you. Yeah, it's an interesting point. I think from the discrete choice experiment, we don't have sort of free text explanation of why they were, what they were thinking when they chose it. But the brief for that sort of spoke of physical comfort and focusing on that. And from the review and some of that qualitative work, one of the big concerns seemed to be about pain. And whilst that might not be directly dementia related, it often relates to the number of comorbidities you may have at the end of life. And so fear of being in pain was really important, or the avoidance of being in pain was really important. I think one of the people in my photo study, their photo was of a hot water bottle, because that's what they used to alleviate their cancer related pain that they had as well. So there was sort of important things around that. We didn't really tease about how that would be measured or estimated. I guess the knock-on thing of this is thinking about how badly pain is assessed in dementia clinically, particularly in advanced dementia. And so the importance of ensuring things like the Abbey Pain Scale are appropriately applied when people aren't able to verbalize. And so I think that's an important sort of consequence of this work is to highlight the need for those things. But it wasn't something we explored directly in the DCE.
Okay, great. Thanks. Okay, we're just about out of time, so I'll do my best to wrap up. So thanks once again to Matt and Liam for their talks. Thanks to you for attending and asking the questions. We will be having the next in this series of research webinars on the Thursday, the 4th of December at 1 o'clock. And the topic will be improving health and care for the next generation. We've got two speakers. Professor Lorna Fraser will be talking about the role of health, education and social care in caring for children with life-limiting conditions and their families. And Dr. Kimberly Whitehead, I think Kim's on the call, I think, yep. She'll be talking about home neurophysiology diagnostics for children with complex needs. So thank you very much. Do try and attend that next event on the 4th of December if you can. Abby will be posting a QR code on the screen and a link will be in the chat. So if anyone wants to give any feedback on the webinar, we'd be very grateful for that. And if you're interested in the Better Health and Care Hub, then the social media tags and the links are also posted in the chat by Abby. So we'll finish just on time. So great. Thanks very much for everyone who contributed. Have a good day.
Thanks, everyone.
Bye.
Bye.
Thanks, everyone. Bye.